I welcome you all for the session. And we have Dr. Darius Shroff joining us all the way from New Delhi. Also, we have Dr. Priyanka, Dr. Indranil Sahab, Dr. Aniruddha Agarwal, Dr. Abhishek Kothari, and Dr. Shashi Narayan. We'll wait for Dr. Abhishek Kothari. In the meanwhile, we can start with the session.
Thank you so much. It's a great pleasure to be here. And today, as the topic suggests, the topic is A to Z of OCTA. And I'll just show you a slide to introduce the session. So I think the basics will be covered by Dr. Priyanka. I'll be speaking on the role of OCTA for CNV. Dr. Indranil Sahab will be covering the topic of diabetic retinopathy. Dr. Aniruddha Agarwal, who is joining us today from Cleveland, from Abu Dhabi, will be speaking on the arterial and venous occlusions. After which we have a very exciting talk on AI, artificial intelligence in OCT imaging by Dr. Kothari. And Dr. Shashi Narayan will be taking us on to OCTA decoding uveitis, which is also extremely important topic. So without much ado, I request Dr. Priyanka to give her a talk on the basics.
Sure, sir. 1 second. I'll do my share screen. Yeah, can you see my screen?
Yes, yes.
Am I audible, sir?
Yes.
Okay. Good morning, everyone. Thank you, Dr. Darius, for giving this opportunity to speak up on OCT angiography, basics and artifacts. 1 second. I don't have any financial disclosures. So the rate of change in innovation is really breathtaking and exciting. And the challenge comes when we try to understand what OCT angiography is and what it can try to accomplish. So the increased resolution in imaging machines has really changed the concept of understanding. Hence, it's not what you look matters, but it's what you see matters. So with the message of seeing is believing, I'll start my presentation. First of all, what is OCT angiography? It's a non-invasive technique, completely dye-less, uses motion contrast to obtain high-resolution volumetric blood flow data and provides localization and delineation of structure as well as vascular pathologies. Now, why do we need the OCT angiography? We need it because it provides three-dimensional visualization of retinal and choroidal vasculature. There is no need of dye injection. It is completely non-invasive, helpful in patients who have chronic kidney disease, allergic to dye, and require frequent monitoring based on the imaging. Another thing, it can able to segment different layers like superficial, deep, which is not possible in the fluorescent angiography. Now, if we look at the PubMed search for the last 10 years, we could see that a lot of studies have been done on OCT angiography, and literature have really provided us some very interesting articles to read. So with the cumulative knowledge, we are progressing further, but yet we need to discover more in terms of understanding, misinterpretation, or links. Are we seeing the true flow or the false flow? So let's start with the basics first. First of all, the principle of the Octa. As we all know, Octa is based on the motion technique, motion contrast technique. So what happens when we repeatedly scans a particular area? So a numerical value is generated based on the sensitivity of that location. Now that numerical value, that memory location is called a voxel, which is a blend of pixel and the volume. And this voxel is attributed to the transitions, which are called noise. So if the signal strength is high, the noise will be low, and the converse. Later on, this numerical value is transferred by the computer monitor as an angiogram. And what you look is like a emphase, which is giving which provides the structure and the flow information. Now, among all these, the flow is very important. How is this? Sorry, motion is important. So how is this motion generated? There are certain tools in Octa to know. First is the speckle, and it's a method of detecting the motion contrast. What is speckle? Light is travel in the form of waves. Now, when it strikes on the reflective surface, it forms a secondary wavefront. That can be constructive or it can be destructive. So constructive wavefront is called a speckle. So what happens if we go back to the principle, when the successive scans are coming, if the object is not moving or it's stationary, there will be no change. But if the object is moving like this, so the different waves front will be seen, and only object moving in the eye is the RBCs, which is contained in the blood vessel. Another important tool is a decorrelation. What is that? It is the amount of change in the region from one image to another. But here in this picture, important to know is what is TS and what is TF. TS is the acquisition time taken by the beam to scan a particular region, and the TF is the flyback time. When the scan has come, it has to go back to its own position. And what is this delta T? Delta T is an interscan time, which is a sum of TS and TF. This interscan time tells us about the sensitivity and specificity of the Octa. Now we have a principle called variable interscan time analysis. Generally, it is a 5 millisecond, but we can increase and decrease. But by increasing the interscan time, you're allowing the slow moving RBCs to giving a greater chance to move between the scans, but yet it provides the image artifacts, and the shorter interscan time will capture the movement of fast moving RBCs before it exits the length of the OCT beam. Another important tool is the masking. Now, why we need the masking? We need it because it helps in image processing. Thresholding is generally applied on the data to remove the regions with low signal or noise. Now, we need a Octa has to be reliable only when the signal strength is high, and only artifacts can occur because of the presence of attenuation. So wherever you will see a low signal, it will appear as black, and wherever there will be high signal, it will appear as flow. So if in cases of low signal regions, if there are random fluctuation of noise, it can create a false appearance of flow, like it's called false positivity. So in a case of RP atrophy or the choriocapillaris atrophy, you can visualize the deeper choroidal vessels, and that can be misinterpreted as flow. Thresholding also means that Octa cannot detect flow in low signal regions. If even if it is present, that is false negativity. So the absence does not mean there is no flow. Let's see, take the example of the choriocapillaries. Suppose in the vascular and the structure, both are giving a dark signal. That means it's a signal loss and in presence of attenuation artifact. But if it is dark on the Octa and it is bright on the structure, that means this OCTA measurement is valid and there is a true flow or the flow impairment, or what we call as flow void. So low OCT signals or the absence does not mean it's a choriocapillaries loss. Another important tool is the registration, which is emphase, and what is the visualization method, what we are seeing. How does a normal angiogram looks like? We have a superficial plexus, deep plexus, and we have a avascular, then we have a choriocapillaries. If you see, all the architecture is completely different from each other. We have a honeycomb kind of arrangement in the choriocapillaries. In the deep plexus, we have this net kind of structure, and superficial is formed by ganglion cell layer, inner plexiform, deep is formed by inner nuclear and outer plexiform. But the beauty comes out when we try to understand the pathology on an emphase visualization. So I have taken an example of RAP. This is a color photo. This is a fluorescent angiography, which is showing a leakage in the later frames. Then we have this OCT, which is showing this outer retinal edema, cystic spaces, and the vascular complex over here. Then this is a color-coded generated Octa map, which is showing this retinal anastomosis. Now, when we put all the infas together or the separate layers, we found this kind of track of the lesion. So this track is like retinal anastomosis emerging from the deep retinal plexus, forming the high tuft-shaped flow lesion at the avascular area, which is connected to the choriocapillaries and the choroid formed by the deep feeder branch. So you can postulate whether this pathology is horizontally placed or it's a vertically placed. So that's the beauty of the infas. Another example I would like to share is of PDR. You can say in the fluorescent angiography, NV looks like this, very hyperfluorescent, but on the Octa now we have a montage facilities where you can mix all the images and can have a wider field of view. So the NVE looks like this. This exuberant proliferation of vessels. You can have thinner branches, you can have peripheral loops. Now when we place this slab placement over this area, you will see the presence of flow. So that gives an indirect evidence that it's an active NBE. And whether it's elevated or not, that you can look in the VR interface lab. So this is a manner how can you read the Octa on an infas. So let's come to the artifacts. Even with the best imaging modality, the images are not always perfect, and there are always extra missing links, which are called artifacts. And what is the rule of imaging? In an imaging system, there is an object to be imaged and an image to be created. The image is a transformation. And what is the rule of the Octa? Octa means you sit on the machine, you see where is area of interest, and then you do the accurate segmentation. So let's start with the first movement artifact, which occurs because of the gross movement of the eye, and you can have a horizontal, vertical, dark or bright lines, how it looks like. Now, as we know, OCT creates this kind of raster pattern, and if there is no movement of the eye, this kind of image will be produced. Suppose the eye move in this direction, the black arrow, then you will see the white line at the junction of two images, and on the OCT angio, you will have this kind of motion artifact. This is with artifact and this is without artifact. Uh, but software do have a capacity to compensate all these all motion artifacts, but then they create their own artifacts, which are called compensated software artifacts. Which are those? These are vessel doubling, where two copies of the vessel will be seen, like shown in the red arrow. Again, then second is displacement artifact, where part of the image is from one region, another from the discontinuous region, and the stretching effect, where the completely image has gone. It's like a stretch, like a rubber sheet. So these are some software artifacts. Another very important artifact is a projection artifact. What happens when OCT beam penetrates a superficial capillary plexus, then a portion of light is reflected back, but some light travels continue and reaches the RP, which is itself a natural reflector. Now, whatever light arriving at the RP is always influenced by the flow present above it, and that's really gives the erroneous appearance of a superficial vessels in outer retina and RP. So this misinterpretation of flow is termed as projection artifact. We have some natural reflectors in the eye, like RPE, plexiform layer. Choriocapillary is very confusing structure. Stroma giving stromal decorrelation artifacts. Sclera can give segmentation artifacts. So these are some examples. Deep vascular plexus is really suffer from the projection artifacts from the superficial vessels as shown by this arrow. Again, this is imaging at choriocapillary, source of confusion, I would say. This is a case of sub-RP neovascularization. Now, when the slab placement is at the level of RPE, you can see some imprint of flow. But when the slab placement has been done just below the RP, the actual vascular network has come out. So this is a case of type 1 CNVM. Another drusense, yes, drusense which are not harboring any CNVM then can produce image that seems to have vessels giving projection artifact. Edge of the PD is really provides false positive decorrelation signal on the Octa image. So these are certain examples, but we have some algorithms to overcome these artifacts, which are slab subtraction of the projection resolved Octa. Slab subtraction they remove the bright, they subtract the Octa and fast image superficial from deep, but then they produce dark vessel artifacts, which are really unacceptable ones. And projection resolved Octa is little better because it provides the continuity of deeper vascular layers. Another artifact is the segmentation errors, which has failed in the retinal edema, atrophy, or high myopes. Interpretation errors can occur, but you can avoid them by seeing the contours in sequential OCT B-scan images. Now we have this very interesting OCT interpretation basic toolkit, which I would like to share. So suppose first step, just mark your area of the interest. What is the area of interest? And then you see the en-face images. See superficial, avascular, choriocapillary. Suppose your pathology lies in the choriocapillaries. So now then take the segmentation line at this level, because improper slab placement sometimes misleads the pathology. Once you have done the proper slab placement, then you look at the B-scan overlay, whether this flow is present or not. Now you have to look whether your flow, what you are saying is true or false. Then you look at the en-face intensity image, whether this is giving the bright signal or dark signal. Suppose it is giving dark signal and it is dark on the this NG also, that means there's a signal strength is low, and whatever you're saying, it's a false flow. So this is how
Sorry
you
to interrupt, ma'am, but the
go.
time is up.
Okay, but 2 slides more.
Ma'am, other discussions will get delayed if we, extend the session. I'll request you to conclude.
Okay,
Just give a summary, Priyanka.
Okay. Just
a few
limitation. Limitation cannot visualize the leakage, and retinal segmentation. It's dependent on retinal segmentation. And artifacts makes interpretation difficult. So top 3 tips: always correlate all the layers. Sometimes video analyzing helps in decreasing the chance of segmentation artifacts, and important to analyze layer by layer. Thank you.
Thank you so much. I think that was a really exhaustive talk and covering all the aspects of the imaging as well as the important topic of artifacts. And I think we can have more discussion towards the end of the session. I'll just share my screen now.
Yes, sir.
Can you see the screen?
Yes, sir. You haven't shared the PPT yet, right?
No, I've shared the PPT. Is it
I
open?
can see the folder. I cannot see the PPT yet.
1 second, I think.
Sir, open the PPT first and then share your screen.
Okay, I think that it was not open first. Just open it. I had actually opened the introductory PPT first. So.
You can stop sharing and share it again.
Okay, yeah, I think now it should work. Is it okay?
Yes, sir.
So good morning, everyone. Thank you for joining us. I think Priyanka has made my job very easy by talking about the nuts and bolts of Octa. So I'll be talking about a very important role of Octa, basically on localizing CNVM, because this is one area where it has a practical utility. So some of the situations where this is very useful is the CSC or central serous chorioretinopathy pachychoroid spectrum to pick up early lesions in RAP lesions, which also Dr. Priyanka has shown. In cases of IJT, where sometimes the lesions are not seen well, in Best vitelliform disease, and also in exudative AMD. So let's go through this. As we discussed already, retina has layers. It's not a vanilla cake. If you just look from the outside, it looks like a white colored cake, but you see the multiple layers. And this is a very important slide. So you can say that the retinal capillary system is composed of the superficial, intermediate, and deep. But see this zone below, just above the RP, this is an area which is supposed to be avascular. And only if there's a vasculature here, this is when we have to suspect as the presence of a CNVM. Let's see a few cases. So this is one of the challenging cases I've been dealing with for almost 10 years. He's a 64-year-old retired brigadier who is not hypertensive or diabetic, who has a history of porphyria, who came with a chronic history of blurred vision in the left eye. And we thought there's a scar in the left eye with some cystic paces. He was not keen on having therapy, and he was lost to follow-up till 2015. That time he presented with blurred vision, and you can see the fluid SRF which has come up in both the eyes. So these are the comparative OCTs, and you can see the fluid coming up in both the eyes. This is the color photograph. There was no polyp, but there was hyperfluorescence on the ICG, and the FFA showed what we thought was CNVM both eyes, and he underwent anti-VEGF ranibizumab in both the eyes. So you can see the anti-VEGF is being given, but there's not much change in both eye fluids after this. And shockingly, 1 month after his third injection, the patient complained of sudden waviness while reading. And we were wondering what is happening, and we didn't know what to do because we're giving an expensive injection, but the patient is not healing. So we did an Octa because it was new at that stage, and we could appreciate these beautiful loops in both the right and the left eye. And when we did a swept source OCT, we could see the choroid is much thicker, also more than 500 micron. The ultra wide field autofluorescence showed these beautiful tracks. And this was when aflibercept was being introduced in India. So we switched to anti-VEGF agent, and lo and behold, you can see this was 2017, the first time we had a dry macula in both the eyes. The swept source OCT done later confirmed these beautiful networks, which you can see on Octa, confirming the CNVM. So what is the learning point from this case? The type 1 CNVM in case of a pachychoroid with a sick RP, patient had porphyria, so PDT could not really be used. But most important, Octa helped clear doubts about the presence of a CNVM and using a expensive treatment option, which did well for this patient. Other thing I want to discuss a bit is Best vitelliform disease. I think a picture is more than 1,000 words. So you can just look at the screen above. The video is coming, and these are cases where the FFA is not very informative at times. But just look at the beautiful network coming up on the video. And once you see this, you're sure that there's a CNVM and you can treat this patient. Otherwise, you may be doubtful. You may get some stippling or hyperfluorescence, but you are not sure whether the CNVM is there. Whereas this is one modality which actually shows you the network. IJT is another interesting disease, and this is also very challenging because very often we are not able to really make out whether the network is because of the IJT itself or is it because of a CNVM which has come. I think it's not, maybe I'll use this. Yeah. So this was the classical classification of IJT, which was given by Gas and Lodi. But you can see initially there are not too many changes, but as you go down to stage 5, you are seeing the SRNVM. So this was a Octa based, also similar, except little difference in this is they've noted the SRNVM to be in stage 4. So let's see a few cases. So when you have a grade 1 kind of a IJT, the superficial layer is normal, but you see some telangiectatic changes in the deep. Grade 2, you see the superficial is mild, but there are marked changes in the in the deeper layers. And when you go on to grade 4, you can see there is the FAZ irregularity and the vascular invasion. But most important for us is grade 5. And this is where what I said in the beginning, the CNVM is noted to be present in the avascular zone. And as soon as you get this thing in the avascular zone, this is a red flag for the CNVM. So this was a patient of ours. If you just see the color photo, it's not really very indicative what's going on. But I think let's go through this again, go through a nice video. So keep looking on this area of the screen. And as we are scrolling down, we see IJT. But when you go down, you can see the CNVM presence. And these dots which are showing flow on the B scan also give you a clue. So I think this is one modality where it's quite useful. Exudative AMD, of course, is very, very important. And traditionally, we use FFA, but FFA poorly delineates the CNVM when it's obscured by things like hemorrhagic pigment, RP changes, fibrosis. So the Octa shows these beautiful images like Medusa head, sea fan, prune tree, etc. And the most common in our experience are the Medusa head, glomerula, and lacy wheel. But what exact implication they have on treatment, we really don't know. So these are some of the features which you see. I think we can go through this because we may not have so much time. But important is that based on this patterns, you can describe it as active or quiescent. So basically features like being well-defined, having a branching network, presence of anastomosis, vessel terminus in the peripheral arcade, or the intense halo. So if less than 3 features are there, it's noted as a quiescent CNVM. And there is a high correlation between the CNVA patterns of Octa and the kind of conventional model of imaging. So that is very important to note. So we can see all the subtypes of AMD using Octa. So this is a type 1. Under the RP CNVM, you can see the beautiful network, and another one also you can see the tentacles. I think the type 2, where it is subretinal diffusiform, this is beautifully picked up. Normally they're smaller networks, they're well picked up on the Octa, and you can see how much more clear it is on Octa than on the traditional imaging modalities. And even this case is where you can see beautifully the features on a Octa. RAP is a case where we do find it does help us. The hemorrhage, of course, gives a clue. And you can see the B scan, you can see the connection of the RAP here. But you can see how nicely you can actually pick up the RAP lesion. And when you do a video angiography Octa of this, you can actually see the connection and the deeper aspect of this RAP lesion. There's a lot of controversy about PCV, whether it is useful or not. But I've seen, let me show a few examples to convince you that it could be useful in PCV also. So what I would like to say is that we see the polyps much better with ICG, but the BVN is seen better with Octa. So these are a few situations where you can see the BVN is the branching vascular network seen beautifully using the OCTA technology. Another case with the peripapillary PCV and how well the BVN is picturized using the OCTA. These are extrafoveal polyps. Again, you can see the polyps are seen well, but if you see the Octa, how beautifully the BVN is picked up, which is marked by the blue arrow. PHCR, which is the peripheral form of PCV, again, you can again pick up these polyps if you try very hard with Octa, and you can correlate them with the B scan also if you have a wide field OC. Can there be a neovascular membrane in non-exudative? So this is a very interesting topic. All studied eyes with asymptomatic intermediate AMD, and they found that 3 eyes showed a plaque with no evidence on FFA on FFA OCT. So this is a very important situation where we are picking up these sort of networks in asymptomatic patients. So the question arises is, should these be treated? Could they be precursors and warrant follow-up, or could they be providing some nutritional support for underlying RP and photoreceptors? So we don't have enough information about this time, but I think it's prudent to follow up these patients more carefully at the current time. So I would just like to conclude that today we have seen some beautiful patterns on Octa, and we can see the CNVM where other modalities may not be so useful. We can even pick up these non-exudative CNVMs, which are subclinical, and maybe future algorithms will be based on the morphology of these lesions. So thank you very much. And
thank you so much, Dr. Darius. Would you like to invite the next speaker?
Yeah, thank you so much. I think now I would invite Dr. Indranil Sahab, and he'll be speaking on the role of Octa in diabetic retinopathy. Indranil has done his retinal fellowship with us, and now he's a consultant at the Sitapur Eye Hospital, where he's doing a great job. Yeah. Welcome, Indranil.
Good morning, sir. Good morning, everyone. Thank you, sir, for the introduction. And after Dr. Priyanka and Dr. Darius, they've already taken the session to top gear. So I will be talking about an OCTA way to look at the diabetic retinopathy, which is a very common case scenario in our OPDs. Is my slides visible?
Yes, sir.
Okay. So why is the angiography needed? So angiography is actually needed to assess the level of ischemia, to document the burden of proliferation, and to document areas of leakage. So when we are doing FFA, the conventional teaching is the early phase tells you about the ischemia, the late phase talks to you about the edema and the proliferation that one needs to deal with. Risks of FFA, that is all known to everyone, that it's an invasive test. So you can't keep on doing it again and again on the same patient. It's nephrotoxic, risk of anaphylaxis, and limited time, as in you have very limited time for the operator to catch a lot of information which would help in the treatment of the patient further. So OCT angiogram scores on this that it's an alternative method which is non-invasive, which is the most attractive factor. And the second thing is the time limit that the operator and the patient have is a little more compared to the limited time in an FFA. So what are we looking at when we do an OCT angiogram? In the retina, we are looking for capillary dropout areas, dilated and tortuous capillaries. In the choriocapillaris, we're looking for flow impairment of flow voids, phase changes for irregular contour or enlargement, capillary integrity loss, microaneurysms which are more appreciated in the deep plexus, any evidence of neovascularizations. The DME is seen as flow void areas in the deep plexus corresponding to the cystic changes. So this is, let us first see a normal to understand the abnormal then. So this is actually an enlarged view of the foveal avascular zone, as you can make out the anatomy so well here. Followed by an affected patient where the red marks the microaneurysms, which are seen as those dilated tufts. And you can appreciate how the foveal avascular zone is so enlarged and distorted, suggestive of ischemia in this patient. For these are actually images comparing the FFA with the OCT angiogram, the microaneurysms, the vascular loop, and then the enlarged foveal avascular zone with areas of non-perfusion. This is the green arrows are again showing you areas of non-perfusion. The red is showing you an IRMA and then the foveal avascular zone. And these are actually the artifacts which were spoken in detail by Dr. Priyanka in the earlier talk. This is another section showing a vascular front in a diabetic patient, which is again a segmentation. And as Dr. Darayas sir showed in his previous slides, you can see the area of the vascular front showing it to be an active lesion. This is a patient of TRD this is the pre-anti-VEGF OCT angiogram, and this is the anti-VEGF after the anti-VEGF was administered. You can see the vascular caliber has gone down markedly, but if you can see the corresponding B scan, there is a little more noise happening here because of the mixture of the vitreous hemorrhage and the blood that was present under the hyaloid. So basically an Avastin injection is given pre-op to reduce the possibility of bleed that these patients have when you take these patients up for a vitrectomy to relieve the traction. This is another comparison of the NVEs that are seen. So you can see the red actually corresponds with the OCT angiogram of the FFA and the OCTA, but the yellow is actually showing the areas of leakage which the OCT angiogram misses. So the peripheral viewing of the OCT angiogram and picking up of details can still be a limiting factor or a challenge. This is an image that which will show this is the clinical picture of the patient, the fundus FFA showing marked areas of neovascularizations with corresponding areas of non-perfusion. And this is a correlation of these areas of neovascularization with the OCT angiogram, where you can see these beautiful lacy networks and corresponding areas of capillary non-perfusion. So this was a classification proposed, which was published in the American Journal of Ophthalmology, which was the types of neovascularization. So type 1, which originated from the venous side and had a tree-like shape. Type 2 originated from the capillary networks, which are octopus-like shape. And type 3, where the IRMAs, which we know are the precursors of proliferation. So these were the NVs that originated from IRMAs and were C-fan in shape. This is another display of NVD. As you can see, this is the NFAS showing you the the neovascularization, active NVD with blood flow areas. And then you can see the pruning or reduce in the caliber of the NVD and a reduction in the blood flow areas post-treatment. These are again, so the picture, the ACE, these are basically irmas showing you the tuft-like projections, a magnified view with it projection above the ILM with the blood flow area. Treated it, the irmas have reduced in caliber, and the projection which was seen on the B scan has reduced and has gone sub-ILM. Another comparison to show the marked irmas with non-perfusion areas, the perfusion is returning post-treatment and the caliber of irmas is reducing. Another slide to highlight the same, where the irmas are reducing on treatment and the perfusion is improving. All this is picked up so well on an OCT angiogram, and you can actually document and show the patient, as nowadays seeing is believing. This is a comparison of again the FFA with the OCTA, where this is the pre-treatment and post-treatment. So you can see post-treatment, the neovasc component has reduced, as in it was thick in caliber, it has become thinner in caliber, but the FA does not show you the areas of non-perfusion, which is still picked up quite well on the OCT angiogram. This is again of an image of a patient pre-vitrectomy and a patient post-vitrectomy, where you can see the advanced proliferation present along the posterior pole of the patient, which has obviously regressed post the vitrectomy. So to conclude, OCT angiogram, as has been already highlighted by the previous speakers, is the new tool in armamentarium of multimodal imaging, a non-invasive tool with comparable and reproducible results. It does have a learning curve where we need to understand how to get the image of interest, segment it well, and reduce the artifact component. Thank you.
Thank you. That was a really nice talk, Indranil.
Thank you, sir.
And should we just move on to Dr. Anirudh's talk, and then we'll take other questions at the end?
Yes, sir.
So I'll just try to share Dr. Anirudh's talk. Is it coming?
Yes, sir.
My name is Anirudh Agarwal, and I'm at the Cleveland Clinic, Abu Dhabi. At the outset, I would like to thank Dr. Darius Shroff for this opportunity to present my thoughts on OCTA in retinal vascular occlusions. Before I begin, a short note here on retinal plexi. We know that retinal capillaries are arranged in a very well-defined laminar pattern, and they form what are called as plexi. Traditionally, we know that there is a superficial and deep retinal vascular plexus, and there are pre-capillary branches that run vertically connecting the two plexi. The development of OCT angiography with projection artifact removal has allowed identification of distinct capillary plexi. So we all know there are superficial and deep plexi, and there are multiple papers which have provided segmentation of the superficial and deep vascular layers. Recently, we realized that there is another intermediate capillary plexus, which is at the inner edge of the inner nuclear layer. So the superficial plexus is within the ganglion cell layer, and the deep plexus is at the outer edge of the outer nuclear layer. With this, we realize that cotton wool spots are essentially ischemia of the superficial capillary plexus. PAM is ischemia of the deep capillary plexus, resulting in an inner nuclear layer infarct. And acute macular neuroretinopathy, or AMN, is ischemia of the DCP, which results in a very different outer retinal involvement compared to PAM, because it involves the outer plexiform layer, outer nuclear layer, and beyond. So both of these entities are essentially ischemia of deep capillary plexus, but remember, they have different manifestations. This is essentially deep retinal ischemia. Now, PAM is a newly described entity, relatively new since the advent of OCT, but we must remember that there is no possibility of only an isolated intermediate capillary plexus infarct, for the simple reason that there are small arterioles which connect these plexi together. So sometimes you may be misled by some of these acronyms which are being used in the literature. So this is a cotton wool spot. It's an ischemic lesion. We know that it affects the superficial capillary plexus. Whereas paracentral acute macular ischemia, or PAM, is an ischemic lesion which is affecting the deep capillary plexus, resulting in internuclear layer infarct and eventual thinning. And it can happen because of either two reasons. One is the high outflow pressure or low inflow pressure. And further, the high outflow pressure is due to venous occlusions, and low inflow pressure, is because of arteriolar occlusion, but also occasionally because of emboli and hypoperfusion. This is the first case of a 45-year-old male with recent onset scotoma in the left eye. And we know that this patient has this yellowish lesion, hypopigmented, just nasal to the foveal center. And we realize that on fluorescein angiography, it doesn't show much, but only in the late phase, you have subtle hyperfluorescence nasal to the fovea. The OCT shows you hyperreflectivity of these retinal layers. And you can see even the inner retina is involved in a particular scan. The ganglion cell layer, inner nuclear layer, is involved with hyperreflectivity. And the OCT angiography is very revealing in this patient. It shows you a distinct loss of the capillaries in the deep retinal plexi. And this patient eventually underwent MRI brain, MR angiography, which confirmed the diagnosis of vascular migraine. So this is nothing but a vasospasm-related PAM. This is our next case of a 54-year-old male with loss of vision in the left eye. He has systemic risk factors, including hyperlipidemia, smoking, and he's hypertensive. And we realized that there is this classic wedge-shaped PAM, which is in addition to the AION, which was diagnosed 6 months ago. If you look at the OCT, there is thinning, and you see hyperreflectivity of the inner nuclear layer and thinning of the inner nuclear layer in the subsequent scan. So that means this patient has actually had an INL infarct. This is a PAM which is associated with cilioretinal artery occlusion, resulting in SCP ischemia and atrophy. So you see that there is an overlap. This is not just the inner nuclear layer, but also the ganglion cell layer. And this is what I meant when I said earlier that you have the arterioles feeding into the plexi. And so often you get a mixed or an overlap between the ischemia of superficial, intermediate, and deep plexi. This is another patient with profound loss of vision in the left eye. He has an unstable plaque because of an angina, and he has heart disease. And you can see the emboli in the blood vessels very clearly, just superior to the foveal center. And this is another nasal view. You can see these yellowish emboli sitting in the vessels. And fluorescein angiography shows you ischemia of the retina. And in the late phase, you can see it more clearly. So this is a PAM associated with retinal artery embolization. Next case is of a 39-year-old female. Now this is moving on to inflammation. And this patient has dengue fever with NS antigen positivity and low vision in both the eyes, but there is a distinct white lesion in the right eye. If you do the fluorescein angiography, there is a late ill-defined hyperfluorescence in both the eyes, and you have a few microaneurysms which have been reported in dengue fever. The OCT is very revealing. Again, there is this wedge-shaped lesion which is very clearly seen on this infrared image. So you always look at the infrared image and then correlate it with the hyperreflectivity that you see in the retinal layers. Now, a very distinct feature here is the outer retinal involvement. The photoreceptors are involved, and there is a focal sort of disruption that you see in the scan in the middle. So there is disruption of the ellipsoid zone and the interdigitation zone. And you can see in the follow-up image number C that there is this discontinuity or thinning of the photoreceptor and ellipsoid zone. This is nothing but acute macular neuroretinopathy in dengue fever, and we published this in the Indian Journal of Ophthalmology. The OCT angiography shows you this distinct loss in the deep capillary plexus. So this is AMN, which is associated with dengue retinopathy. And just to reiterate, it is very different from PAM that we described earlier, because in AMN, you have the involvement of the ellipsoid and photoreceptor zones, which are not seen in PAM. But again, there could be an overlap between these two entities. So there have been authors who have used OCT angiography to monitor the ischemic areas in branched and central vein occlusion. And you can see in the follow-up, these vascular collaterals are very easily seen using OCT angiography in a follow-up patient with BRVO. Especially, you must look at the deep capillary plexus because these collaterals are very much visible in this particular segmentation slab. This is an image taken from a recently published paper in PLOS ONE. Similarly, improved quantification methods have brought about number of indices. And we have been also working on some of these indices, and these include branching of the vessels, the geometrical pattern of branching, the number of branching, the branch length, as well as the Euclidean length. So all of these are new parameters that have been applied from various fields such as astronomy and geometry into the OCT angiography images. We always had the vessel density with us, but they are newer indices and they may be sometimes more sensitive in detecting ischemia or loss of vessels. As you can see in the CRVO eye, you have decreased density compared to the fellow eye in the deep capillary plexus. So we've always seen that the deep capillary plexus can be much more revealing in these particular patients. And with this, I'd like to conclude by stating that the deep retinal ischemia, including AMN and PAM, can be visualized clearly on OCTA. And OCTA is very useful in detecting retinal ischemia in CRVO and BRVO. Quantitative measurements with OCTA, especially using the newer indices, are very much possible, and they're very helpful in assessing patients with CRVO. Thank you very much.
Thank you. Thank you so much. I think Dr. Anirudh is with us, but I will take questions towards the end of the session. So I don't know if Dr. Abhishek is there. We can have his talk, or
no, even I don't think Dr.
Shishir, you can start, please. Dr. Shishir is right there with us. He's a senior Uveitis consultant and Trophy Center and one of the leading uvea people in North India. And it's a privilege that he's part of our course.
Thank you, Darius, for that kind introduction. And I won't take much time. Anirudh, you had a wonderful talk, and you can always give your comment at the end of my talk because you are a stalwart even in the Octa in uveitis, and I have always benefited from your talks. So you see, there is the importance of vasculature in any patient of uveitis. You see here that there is an area of activity over here, and here the external limiting membrane is disrupted and the ellipsoid zone is disrupted, but here there is a complete loss. So here the circulation is still there. That means this area is still salvageable. While once you've lost the circulation, that means there is not much to salvage. So that's the importance of the circulation in a patient of uveitis. Classically, when we are looking at uveitis and Octa, we want to see the white dot syndrome, which is a constellation of various inflammatory disorders affecting the outer retinal layers and choroid. And we'll talk about a few of them and their protein manifestations. When I was a fellow, we had to learn the pattern recognition of fluorescein and ICG leaks to try and label these entities. And we didn't really understand the exact pathology that was causing the disease entity. Now with Octa, we are able to understand more and more. So PIC is one entity which shows a very small punctate lesions in the retina. They may be pigmented if they are healed, and sometimes if they are active, they'll be in this creamy color. But what is important is that there is not much to be seen here in terms of the changes in the circulation in the choriocapillaris layer. But about 40 to 70% of these patients have got a choroidal neovascular membrane. Now, in this patient, a subtenon tricot has been given, which has decreased the inflammatory component, but you can see here that the component of blood flow is still present. So what has happened after the injection is that the CNVM is still persisting because it's an injection of steroid while the inflammation has gone down. So the importance of multimodal imaging, especially Octa in PIC, is to look for the CNVM. Now, when we come to mutes, it's another interesting entity where the Octa has helped us to understand that there is no changes in the retinal microcirculation and at the level of the choriocapillaris and the choroid. But then what is it that is causing those spots and dots? So you see in mutes the white multiple lesions which cause the larger spots and the finer dots. These are present closer to the fovea, while these are dispersed over the posterior pole. So here is one patient of mine. You can see these white dots here, and you can see that there is a disruption of the ellipsoid zone that is present here. But the ICG is showing multiple hyposinuscent areas all over the fundus at the posterior pole, nasally and inferiorly. Now, this is confirmed that with the EOG and the pattern ERG, as well as the multifocal ERG showing that there is a decrease in the perifoveal response. But when you do the Octa, you find that at the level of the choriocapillaris, as well as in the deeper choroid, there is no change. So um, in mutes, there is no microcirculatory change. And this has led to the concept of understanding that the inflammation is at the level of the photoreceptor, and it has led to what we call photoreceptoritis, and there is a disruption of the loss of the inner and the outer segments, and once it regenerates, you get the retinal function back again. And what you are seeing, the hyposinuscence in the ICG, is actually a masking effect because the outer retinal changes and there is no actual response involvement of the capillaries or the choroid. Now, when we come to serpiginous-like choroiditis or serpiginous choroiditis, which is very common in the Indian subcontinent, you see here a large lesion that is infecting the posterior pole, and you can see the autofluorescence that is helping you to see the active edge. When you do the spectral domain OCT, you can see a localized area of inflammation that is very classically seen here. And then the OCT angiography is showing you the areas of non-perfusion or capillary voids that are present there. And as the inflammation comes down, the thickness comes down, and you see that the voids are going away. So in serpiginous like choroiditis, one very important thing is that you can monitor the response of treatment by the looking at the capillary voids. Probably it is not helpful in diagnosis as much as it is in the management of these cases. And this is here a case where there is a large serpiginous patch over here, and there is a CNVM that has developed at the edge. I will like to share one very interesting case that I have been following up for 1 decade now. So this patient presented in 2011. This was the lesion here. And at that time, we did not have an OCT-A. So you saw this lesion in 2011. And till 2014, this lesion remained stable. In 2015, they started to increase, and obviously one would think that this is a reactivation of the serpiginous-like choroiditis patch that is present there. And in 2015, towards the end, a small hemorrhage came here, which could then be imaged by the then modalities of autofluorescence and fluorescein angiography. So we missed a very early choroidal neovascular membrane till the hemorrhage came. So that is the importance. And now we gave the loading doses of anti-VEGF, and that worked. And now we monitor this patient with an Octa, and we can do a SSOCT and see that the CNVM is stable. So there has been a paradigmal shift from fluorescein angiography and autofluorescence to looking for these subtle choroidal neovascular membranes in these patients of choroiditis. And Anirudh has been working extensively, and his group at PGI earlier, where he was, have actually staged the tubercular multifocal serpiginous choroiditis into 4 based on the fluorescein angiography of autofluorescence and also on the OCTA findings. Then looking at AMPI, That's again one place where you can see the voids at the level of the choriocapillaris. And what is interesting is that these voids of ischemia are beyond the areas of the clinical lesions. So as Anirudh had said, you must look at the red-free photograph, you must look at the en-face image, and then you correlate whether these are masking lesions or these are lesions which are true voids that are present. So here you can see that the void is larger than the retinal lesion, implying that there is a true capillaritis at the level of the choriocapillaris in MP. This is VKH. We now know that there is fluid here and large voids are present, and these are true voids, and they can be monitored serially, and they correlate more with the ICG angiography, and after treatment there is a complete resolution. So when there is a diagnostic dilemma between whether it's a CSR or it's a VKH, what's important to realize is, then this is again another one of the papers from Dr. Anirudh, who's here, and that the masking that you have in CSR correlates with the fluid, while that in the case of VKH, you have true voids which are larger than those that you can see clinically or on the en-face image. So that helps you to differentiate a VKH from a CSR. Then the ultra-wide field angiography is now being done as an Octa as well, and you can see that in retinal vasculitis. You can do a montage imaging, and you can have a really good picture of what is happening in retinal vasculitis as well. So now, from what I showed you, the fluorescein angiography, where you're looking at early hyperfluorescence with late hyperfluorescence, and you're trying to look at block fluorescence and trying to see whether it's a pigment or a hemorrhage. We are now going towards pattern recognition of Octa images in uveitis. You can see that in retinal vasculitis and in birdshot choroidal retinopathy, it is the superficial and the deep capillary plexus that is involved. In nudes, there is a normal flow without any involvement of the inner or outer circulation, and that helps you to exclude other choriocapillaritis. MP has got a flow reduction in ischemia in the choriocapillaris and the choroid, and in PIC you can see the CNVM that is important, which is the most important component. In serpiginous choroidopathy, you have flow reduction in the active lesions, which decreases and resolves as the inflammation is coming under control. And in VKH, you can have focal flow voids, which respond very well to treatment. So now the pattern recognition in Octa is helping us in making a definitive diagnosis. Thank you very much for your kind attention.
Thank you so much for this extremely lucid talk and going into all the details of this entity, which is so important for us. And I think Dr. Kothari has also joined us. So we'll move on to the next talk. Thank you, Dr. Shishir, again. Thank you.
Thank you.
Yeah, so good afternoon, everybody. And my talk is not on Octa, but on OCT, the routine OCT that we have, and how artificial intelligence is changing the way that it has increased its applicability in a lot of clinical situations. So I have no financial disclosures. Now, OCT, as we use it, we get printouts like this, or we go to the machine and scroll up and down on a macular cube. So you get good visualization of subretinal and intraretinal structures. You also have a reasonable amount of qualitative and quantitative data. But most of our decisions and perceptions currently are made on qualitative assessment, not only on the numbers. And there's a huge quantity of data that is ignored, especially in quantification. So if you look at quantification, we usually look at the CMT or subfield thickness. We very occasionally do look at the retinal volume also. But most of the times, if we have to measure, we go for manual measurements. That is because a lot of times the segmentation is off, and we use predominantly quantitative data for temporal comparisons. Most quantitative measures are non-specific to the pathology, like macular edema, or for that matter, intraretinal fluid can be present in several pathologies. So it's not very specific. And the limitations current system are that, depending upon the system that you are taking a scan on, there are scan variabilities, there are artifacts, and whenever there is a cataract or a media opacity, the low signal to noise ratio makes the interpretation of the OCT difficult. You have erroneous segmentation. So for example, in this particular example that I have showed, the system will actually tell you that there's an increase in the thickness rather than the actual decrease that has happened. Also, there is a lack of software to segment the individual components of a disease. For example, I'll be sharing that in my presentation later on. Also, if you want to do a manual segmentation, the time required is massive. So these are the challenges. One is the resolution of the images. The other is the measurements of quantification, the very limited quantification that we currently have. And the challenges in research in this field are basically difference between the vendors and very limited availability of training data sets and distinguishing between different pathologies. So there comes the role of AI in OCT. And this, just as a joke, this is actually a true email. Radiology, there are so many functions that have been taken over by AI that even when I first looked up AI and the first presentation that was given to me about AI and OCT, the first thing I thought that radiologists are going to go out of business. There's so much that AI can do. So jokes apart, what is AI? AI is a very broad term. Artificial intelligence is a broad term which it is used for any technique that enables a computer to mimic human intelligence and to use logic. Machine learning is one subset in which you teach the machine and then subsequently the machine does the task for you. But the most exciting part in which we are working extensively is deep learning, where you don't really have to teach the machine. You just have to present it certain marked images. The machine learns on its own, and then it continuously improves as it goes. So these are algorithms, deep learning algorithms learn. So this is a depiction. For example, if you want computer software to identify a car, in machine learning, you tell the computer, you make a software which tells you these are the components of a car. You find this, label this as a car. Whereas in deep learning, you just give it 1,000 images of a car and it learns on its own what a car means, and then it independently tells you what a car is. Now, whereas the machine learning and the routine artificial intelligence does not learn after a certain time, deep learning algorithms keep on learning as they acquire more and more data, and a lot of times they exceed the human abilities also. The error that we've been seeing over the years in their interpretation and in their identification of features has decreased logarithmically. Now, broadly, AI in ophthalmology has two tasks. One is a classification task. That is a yes/no task. For example, you all must have heard of AI being used to identify diabetic retinopathy. A lot of these large firms are using it. Google, Microsoft, they're all into it. So there they take a fundus image and classify on the basis of certain features, presence or absence of features, into one or the other category. The other and the little more difficult task is the segmentation task, where you take an image and you read the image in the sense that you identify certain features of the image, you quantify them, you mark them separately for presentation that can be used for further studies. So the quality of an image is very important here, and for subjective assessment, it's better to have better images because they lead to avoidance of errors. And for automated analysis, it's even more important. So this is the routine OCT scan quality that we get from 4 of the major vendors: Cirrus, Topcon, Spectralis, and Nidec, which are there in our clinics. So the first task that we did was to first identify the artifacts that can create noise. And this is completely, the motion artifacts are completely dependent upon the speed of acquisition. So when you have a denser scan, it improves your scan quality, it reduces the number of extrapolations that you have to do, but at the same time, it increases the time. So a routine machine, a Zeiss scan takes 1.7 seconds. If you go for the highest machines available now, it takes 0.7 seconds. But if you're going to increase the density, if you want more information, it is going to take 14 seconds. Now, nobody can hold an eye still for 14 seconds. And this directly degrades the resolution and the accuracy of your thing. So this is what I wanted to show. So if you take a raster radial scan, all the areas in between are going to be extrapolated in all your calculations of thickness and of volume. Whereas if you take this, the amount of extrapolation between lines is less. But then there are so many more number of lines also that are being points that are being scanned. If you really want a very good scan, you need to scan with this kind of a density, and this increases the imaging requirements. So can we basically improve the image without having to resort to that? So this was one of our projects. So we estimated the noise in different OCT systems and modeled them into statistical models. So these are the models that we found on kinds of noise in different kinds of machines. And then we verified this using a fixed artificial eye to find out the noise, and these are our results. So if you see the top left corner, that is the original image, and the bottom right corner is the one that we get with our artificial intelligence algorithm by removing the noise. So you get a much better picture after noise removal. These are again examples of the noisy image and of the denoised image using our methods. So these are again two examples. You can see how much better your image quality becomes. So again, this is experimental result on a Duke data set, and this is on my own Cirrus data set. The image quality and the layer identifications become much better. The second problem was, once you improve the images, can you do a layer segmentation? Now, layer segmentation is fairly easy in normal images, but when you have distortions, morphological distortions like cysts and all, it becomes really difficult. So we developed an algorithm using AI, which identifies the major layers of the retina fairly reproducibly, and we've got very good results with that. Now, fluid in the retina is present in so many pathologies. Is all fluid the same: intraretinal, subretinal, and sub-RP. When you look at the OCT data, it presents your retinal volume. It does not exclude a subretinal fluid from intraretinal fluid. It just gives you a total volume. But you all know that it has different implications. So we worked on this to not only segment the layers, but to segment the fluid spaces in the retina: intraretinal, subretinal, and sub-RP. And we developed an algorithm based on a convolutional neural network. And these are the kind of results. This is intraretinal cyst segmentation. So this is the sample scan in the top left corner. And if you look at the right columns, these are the results that we are getting. In between, the middle column is the ground truth marked by a human observer. So we achieved a fairly good amount of correlation with the human observer. Then we also added certain denoising techniques to further improve it, and we got up to 80 to 83% correlation. This is what results we are getting with subretinal fluid segmentation in CSR cases. We can easily completely identify the fluid and then quantitate it into the volume also. So you can, and here the correlation that we get is almost 90%. Then we integrated all these methods to get a way to quantify all the three kinds of fluid: intraretinal, subretinal, and sub-RP. So if you see the OCT image, the image B is the one ground truth marked by a human observer, and E is what our algorithm is giving. So again, this is an example of a fairly complicated image, but now we are able to identify all the fluid compartments also separately. Again, this is an image of AMD with a fairly distorted anatomy, and you can very clearly identify all the fluid components. Now, what is the utility? So we are going to develop this as a web-based tool, so anybody can upload their images and receive the process output. Till now, 2D segmentation is very easily available, but now we are looking at 3D volumetric data. So when you treat a patient of, say, DME or AMD, you will get to know how much of the intraretinal fluid is reduced, how much of the subretinal fluid is reduced. Is there a particular treatment modality that works selectively on one of these components? So if you have a case that has one particular abnormality in predominance, you can use that modality. All plus, in a case like chronic AMD or in a case like retinal dystrophy, you can actually find out the volume of a particular layer, and you will get to know whether that particular layer is less, and you can even make a diagnosis based on that. A very interesting thing is that artificial intelligence is being used to make an Octa from a routine OCT image. Even if you don't have an Octa machine, artificial intelligence will pick up all the vessel shadows and integrate them, and give you a beautiful Octa representation. This software is not clinically available as of now, but I think it's going to be available pretty soon now. So we have got a series of publications for those who are interested in this kind of work with our group at NIT Surathkal. Thank you so much.
Thank you so much, sir. The session is open for panel discussion until 12:50.
Thank you so much. Do we have any questions from audience which are coming in, or?
No, sir. If you have any questions regarding any of the presentations that you just saw, you all can hold a panel discussion.
Okay. So I think, Priyanka, I think we start off with you because yours was the basic talks. So according to you, Which is the most common artifact that you are seeing in Octa, and how do we get around? How do we get around it?
The most common artifact we are saying, we are looking for the projection artifact actually. Most of the times we are misleading the diagnosis because of the projection artifact. And we can overcome because there are some algorithms like PR, Octa, projection, resolve, Octa, that is incorporated in the software itself. So we can remove those artifacts and can reach the diagnosis.
Yeah, I think the important thing is that we have to spend time on the machine and maybe scroll through the video ourselves, because earlier we used to always depend on some printout given by a technician. But in Octa, if we depend on that, it may be fallacious because there may be an artifact involved. So I think what the lesson is from in Octa is that we need to spend more time.
Yes,
FFA, etc. ICG takes like half an hour to do, but the interpretation takes few seconds. But this is the other way around. It may take a few seconds to do, but interpretation takes more time.
Yes, sir, absolutely.
If I can go ahead.
Yeah.
So again, a question for Dr. Priyanka and
Yes,
for the rest of the panel also. In patients who have distorted retinal anatomy,
yes,
what
sir.
if the scan is not of excellent quality? Something like a signal strength of 4 or 5.
Yes, sir.
How frequently would you get artifacts, or would you have to spend a lot of time drawing the retinal boundaries, the retinal layer margins?
Sir, actually, whenever the signal strength is low, there are some factors regarding it, like media opacity, like cataract or the dry eyes. So we have to take care about it. We have to, like dry eyes, we can put some lubricant so we can re-image the scan again. So there are things we have to look for it.
I think very challenging are the very high myopes. Dr. Abhishek, how do you manage those cases? The very, very high myopes also we have a lot of issue. Although with swept source, I think it's still better. We are still managing to get scans, but otherwise it's quite challenging to get good quality scans at high myopes, especially structural OCT we still get, but Octa is a big issue.
Quite correct. So any particular niche application, again, Dr. Priyanka, any particular niche application where you think that Octa would score above, say, a routine angiography, either camera-based or SLO-based?
Sir, actually, there are certain conditions like CNVM, CSR with CNVM. So where you really did not know whether CNVM is hidden or not, Octa is really helpful in those patients. And we have seen quite a few patients. I think Dr. Darai is also with me. So we have certain patients where we have ruled out CNVM in a patient of CSR, especially pachychoroid entities. And nowadays we are doing in PCV also. And sir has shown quite a few images, nice images where we have seen PCV. However, PCV polyps looks good in ICG, and BVN looks good in Octa.
Dr. Shishir, how useful do you find this in your UVR clinic? Because this small CNVM sometimes are really challenging. On FFA, you just see some fuzzy hyperfluorescence. Has Octa helped you in such situations?
I think it has dramatically changed the confidence that you have in interpreting what you're seeing, and in also understanding what the disease process is. I showed in my talk one patient whom I was following up in slow motion. Some of these inflammatory CNVMs can be very slow growing, and you don't pick them up, and the lesion has come from the arcade right close to the macula, and then it has bled. And the moment it bleeds, you know that you're dealing with a case of CNVM, and the effects are superimposed in a angiography. In a conventional angiography, all the various layers are superimposed. So if there is a deep CNVM and there is something overlying it, then it will change the typical pattern. So I think it makes a huge difference in pick. Probably you pick up the CNVM straight away, and you don't have to treat the inflammation. You have to treat the CNVM. What do you say, Dr. Anirudh, to that?
Yeah, Dr. Anirudh, what would?
I think
I don't know. Anirudh actually is joining us from Abu Dhabi, so I'm not sure whether he's.
Sure.
Because I had
I think one of the another application which I found Octa useful is pregnancy. Sometimes, and especially if you have uveitis complicating pregnancy, sometimes you're not very sure it's a CNVM or it's a uveitis patch. We've had recently a couple of cases.
Yeah,
I think that's one of the very good indications where there's no hands down Octa is required.
Yeah, and again in pregnancy, CSR is again a higher incidence. So now Octa, if you do the Octa, you see that there is no change in the circulation. Then you know that you're not dealing with the uveitis, and you are just having the masking effect. So even a normal Octa actually excludes certain things like choriocapillaritis, which you would not be able to know otherwise.
And what about the flow voids? How useful do you find? Are you titrating your therapy based on that in VKH, etc.? The immunomodulation, etc. Do you titrate on steroids?
This is part of multimodal imaging. I won't say that just Octa would help. So in VKH, the choroidal thickness is sensitively calculated now with the swept source. It gives you a very good idea of the thickness, and you can serially study it. Along with that, what we used to do was to do the ICG, and ICG used to show the flow voids, which meant that the clinically the disease is quietened, but it is still active at the choroidal level. Now the flow voids that are happening are actually a functional imaging, so you can actually quantify these changes, and you can not only do an structural changes or anatomical changes which you are seeing on choroidal thickness, you are also seeing the flow voids, and they both will resolve as the clinical condition improves. So the end point would be normalization of the choroidal thickness and normalization of the flow voids. So we have here an opportunity for a functional as well as a structural prognosis.
Thanks, Dr. Shishir. Dr. Indranil, which situations in diabetic do you think Octa is almost vital for us? I think you are on mute. Indranil, you are on mute.
Sir, in diabetics, the only first condition where I would prefer to do an Octa would be if there is any contraindication, as in if he has or had an anaphylactic reaction in the past, or if he's severely renal compromised. Secondly, yes, the Octa does show us the other vascular details like an IRMA much more better compared to maybe an FFA. I mean, at least the pre and post treatment details. So I feel nowadays as I said, seeing is believing, and patients do require a lot of counseling because diabetic treatments is a long treatment with it, be it injections, be it lasers. So we can actually, if one shows them, see, this was pre-treatment and this was post-treatment, the patient does have confidence in us as if something is going good with him. And that's why the importance of multimodal imaging, which I feel today Octa does play a role in.
The rest, macular ischemia would be very nicely
Yes.
documented, and we had something called the featureless fundus where nothing was seen. Of course, angiography, if you pick up an early frame, you will see the non-perfusion, but here you have a way of quantifying the superficial and deep capillary plexus, and you can know what is happening truly and serially with your treatment in macular ischemia.
Even the featureless retinas, we are able to see more features now with Octa, because you're able to see even whatever remaining vasculature in more detail, and anatomy is much better seen. So I think that's very useful for. So
yes, actually, one of our postgrads is doing a thesis where he's comparing the OCT angiogram to the FFA, and the images that he has collected, they do show we are understanding the macular ischemia much better when we do a comparison with the FFA images, as in the details are much better on to see the macula or the ischemic features.
What scan size are you using, Indranil, for this? Are you using a wide scan or the macula only?
Sir, so we are keeping the posterior pole scans during the early scan images, and we are using this software ImageJNet to do the comparison between the FFA and the OCTA images. That was one of the slides that I had shown also. So when we are comparing the FFA of the macula and FFA OCTA, where one can see the macular ischemia and those adjoining tuft-like microaneurysms very clearly in an OCTA.
No, that's nice. No, what I meant is it a 6x6 scan or
6x6, sir? A 6x6, sir.
Okay. Okay. I think I have a Dr. Shishir.
Yes.
Any comment?
No. So it's just that the next session is going to start very soon.
Yeah. I think one last question, I think, for
Yeah,
Dr. Abhishek. You have said the radiologists are going to be replaced. How soon is it before the retina doctors are replaced by AI? I think.
Yeah, so luckily, we are at an advantageous position because our only probably 10 to 15% is image based. Their work is almost completely image based. So what we can definitely expect is that your and Dr. Priyanka's complaint will be taken care of. So your complaint and Dr. Priyanka's complaint was that you can take the scan very quickly, but takes hours to interpret that scan. So you will be free to do more surgeries because AI will take over that job for you.
It will take over the labor that we are putting in. It won't
Exactly.
replace us. It is actually going to augment our work. We can see 100 patients instead of 20.
So unless you have somebody who's just looking at images and telling you, giving you the reports, well, their job is in danger. But because you're going to give the injection based on those reports, you are safe.
Absolutely.
So on this, I think this positive note, I think we can conclude. And thank you, everybody.
Thank you for.
Thank you, sir. Thank
Everyone
you,
can put
sir.
on
Thank
the
you,
camera.
sir.
We can have a group photo.
Can we?
Yeah, we can.
Yeah, I'll do the screen share 1 second.
Yeah.
I will do that.
So you will come?
Yeah, 1 second.
I've done a print screen, so I think I'll get it.
Yeah, I've done it.
Oh, wow. Achha.
Okay.
Great, sir.
Thank you, everyone.
Thank you, sir. Thank you so much.
Bye.
Bye, the rest.
Thank you, sir.
Thank you, sir.